Hello, good afternoon. Thank you so much for having me. It's my pleasure to be here to share with you. I will need to put this myself. We are going to talk about one of the world's largest health problem around the world. So this is interesting in the field of psoriasis. These are my disclosures. This is the agenda. So I will share first about the problem and then about two different solutions. One more about treatment and also about prevention. So things were not so bad some time ago, as you can see here, but in the last year the numbers have changed dramatically, increasing a lot, and it seems like this inertia is going to be difficult to change, and that's why bringing this here is so interesting. And I know you want to know about numbers, and look at here. In America, 73% of the population has overweight or have obesity. So these numbers are really high, and this is difficult to work. And this has some consequences, some relevant consequences, as you can see here. Even in the normal values of BMI, a small increases actually are associated with an increased risk in type 2 diabetes, coronary heart disease, and this ultimately is a cause of a reduced lifespan, as you can see here, being now one of the leading risk factors for early death in our society. So it's a serious problem. And why talking about this in psoriasis? Well, I love this concept published in Nature about the immune-metabolic diseases. We've been talking a lot about metabolic syndrome, cardiometabolic syndrome, but we like immune-metabolic syndrome really suggesting how in an evolutionary process, some hormones can act as cytokines, and some cytokines can actually act as hormones when there are some variation in nutrients. So when you accumulate fat and when you accumulate nutrients, these cytokines can be elevated and they can cause systemic inflammation. If we go now to psoriasis, and this is data from Spain, but can also be in other countries, we have observed, as you can see there, that the prevalence of psoriasis in our countries is twice as high as in the general population. And this is not only for for severe cases, but also for mild cases with odds ratio around 2. So it's an important problem. And you may say, okay, Álvaro, but what happened in psoriasis, and so what? Which are the implications for our patients? Okay, I will cover 3 of them. First, we now know, and this is interesting for Mendelian randomization studies, that actually obesity and an increased BMI is causing psoriasis. So really advocating or suggesting that we could prevent psoriasis if we treat obesity. So this is why we are here, to change our mind and to move through prevention. Also, comorbidities. What about comorbidities? We now know, and we have done many studies where all of our patients in our cohorts is evaluating cardiovascular risk in psoriasis. Always obesity, those patients with high BMI, they have higher coronary inflammation, coronary disease, insulin resistance, liver disease, even liver inflammation. Everything is more complicated, which is positioning obesity in the central aspect of this inflammatory crosstalk that we have in comorbidities. You can see here related to insulin resistance, which we have many biologics, many drugs for psoriasis, but we haven't done well treating, for example, insulin resistance in our patients. So this is why this symposium is so interesting today. And I wanted to bring here an example of this. So this is one of our studies. Here we put together 3 different international cohorts, ours in Madrid, also one in the States, and another in the Karolinska Institute. And here we wanted to answer one question. Do you know that in the cardiology field, the cardiologist has this concept called residual inflammation. Residual inflammation is those patients who had a first heart attack, then they treat them, and they have new events. Their LDL cholesterol is perfectly controlled, but they have a CRP above 2. So I remember one day speaking with Dr. Joel Gelfand, and he told me, Álvaro, you should look in the cohort. Our patient, after biologics, doing well in the scheme, who are those patients who have elevated CRP above 2? And you can see here that the only variable that is validated and significant across 3 different cohorts is obesity. So what this is suggesting is that when you have a patient like this, we use our treatments. We can do this now, but we as dermatologists think we are done, like we are okay, but they still have some systemic inflammation driving comorbidities, and this is something that we still need to work on. And the third problem of obesity in psoriasis is the efficacy of our treatments. We now know that obesity is associated with a poor treatment response to biologics. TNF are more impacted, followed by IL-17 and followed by IL-23. But this is a problem among all biologics now. Okay, so these are where our unmet needs in psoriasis and why obesity is at the central point in all of these things. But we are here to talk about solutions. And as Einstein said, a clever person solves problems, a wise person avoids it. And here in the IPC, I think we should be clever and wise. So we should do both. And we have evidence that if you lose weight, you actually improve psoriasis outcomes. And this has been demonstrated, losing weight by diet, by surgery, by drugs, and also in patients, all kind of patients, receiving biologics, receiving topicals, and also improving psoriatic arthritis. So we know that losing weight improves psoriasis, but you want to know the numbers. What can I tell my patient? Okay, you can say to your patient that if the patient loses 5% of his weight, he's going to improve actually 26% of their psoriasis. So it's worth trying, and also because when they lose weight, they also improve all the cardiometabolic comorbidities. So it seems to be interesting. But I know you are looking at the slides, and you may say something like this. Okay, Álvaro, but losing weight is impossible. And it's okay, my patient tells me it's impossible to make them losing weight. So what can we do to lose weight in our patient? And I think here is when the story gets interesting, right? So we have some treatments. And as you can see here, we can do surgery, and you can see the percentage of weight loss that you can expect from that. But also we have new therapies for this, semaglutide, liraglutide, and you can see there about 15% of weight loss, 9% of weight loss, and the last one here in the New England Journal of Medicine recently, tirzepatide, an oral drug, is a GLP-1 dual, GLP-1 and GIP inhibitor. You can expect 20% of weight loss with these drugs. And the interesting thing in psoriasis is that they appear to have some pleiotropic effect. So not working only on weight loss or insulin resistant, but also in the cardiovascular component of the disease, which is interesting in our field of psoriasis. And here I show you an example of a recent paper, another New England Journal of Medicine. You can see with semaglutide. These are not type 2 diabetes. So obese patient with previous cardiovascular disease, you can see a reduction after 48 months in cardiovascular events. So here again, treating obesity with new drugs, you can see prevention not only of many problems that they have. And if you want more reasons, here I bring Dr. Gelfand. As you can see, psoriasis have also been demonstrated to be a risk factor for type 2 diabetes. So in the story, we have obesity being a risk factor for psoriasis, psoriasis being a risk factor for type 2 diabetes. They share some genetic and immunological components. So why treating all these things separately? So treating psoriasis, then diabetes or obesity. Could we treat all these things together? And here is when the hot topics arise. So there are actually some clinical trials with an endpoint of PASI score with these GLP-1 inhibitors. These are type 2 diabetes with positive results, but the sample size is small, is 13, 11. For me, this is just hypothesis generating. We need another kind of trials, but it's actually interesting. You can see improvement in PASI score. We have also systematic review and meta-analysis with observational studies, also with positive results in patients with psoriasis, with PASI score as an outcome. Again, observational data in type 2 diabetes, so we need more clinical trials in large sample sizes and maybe with different outcomes like this. This is a clinical case, but I think represents really well what we need in psoriasis. So it's a woman with psoriasis, not doing well on biologics, obese, type 2 diabetes. beginning semaglutide, and after 10 months, you can see improvements in PASI score, improvement in insulin resistance, CRP, and very interestingly, in epicardial adipose tissue. So this kind of outcomes we should also include in our trials in psoriasis. Okay, but as a society, if we only treat our patient with drugs, with biologics, and we inject things, we give pills, maybe we are not doing well. We need to change behavior and if we want to go to prevention, and here is the second part. Patients want to know about diet, and we want to know about diet. If you go to the IPC YouTube channel and you look for the most popular videos, they are about diet, 2 of them about that. So we need to solve this question with rigorous evidence. And we know that losing weight works well for psoriasis, but are there any anti-inflammatory diet? Is there any diet which components may help inflammatory processes beyond weight loss, which could be interesting? And here I bring these 2 trials from my country, from Spain, one published in the New England Journal of Medicine and the other one in the Lancet. This is general population. It's not psoriasis, but can be very helpful to us. So first one is primary prevention of cardiovascular disease. You can see Mediterranean diet enriched with extra virgin olive oil, a reduction after 5 years in cardiovascular disease in MACEs. And this is secondary prevention. You can see prevention of a second MACE, and also with the same Mediterranean diet enriched with extra virgin olive oil. And then they went to this patient in primary prevention, they measured interleukins, and they show reduction in the group of Mediterranean diet in TNF-alpha and also in IL-6, CRP values, so they potential benefit in chronic inflammatory states because the control diet is a low-fat diet, and it's increasing IL-6 and TNF. So this makes sense in psoriasis. There are some observational studies. I don't have time to bring them all, but also this extra virgin olive oil correlated with improvement in PASI score, the whole diet, a big, large study with questionnaires, observational studies also suggesting some positive effects of the Mediterranean diet in psoriasis. So, which is the evidence? We have first evidence level A. If you have psoriasis and are overweight or obese, you should lose weight. Good. Then the best diet for psoriasis with a level of evidence C is the Mediterranean diet with extra virgin olive oil. And the third point, of course, we need more evidence for this. And that's the reason why we have begun, in my center, we have begun this clinical trial. This is a pilot clinical trial in preparation for a larger grant. Here we have an intervention group and a control group for 4 months. The outcome is not only the PASI score, but also cardiometabolic parameters. This is our intervention. So when you say, what is the Mediterranean diet? This intervention can be measured. So it's about 4 tablespoons of extra virgin olive oil, which is quite expensive, and I am looking for the biosimilar of the olive oil because it's so difficult and we need to figure out this. You need 3 portions of fruits, 2 of vegetables. You love the wine, right? Then nuts and fish and so on, and avoid processed food. So this is also interesting. And you are there and you say, we want this to be practical, so what can I do in my clinical practice now, tomorrow, when you go to your clinic? For me, 2 kind of things. First, we need to get used to these new drugs, to this GLP-1 inhibitor, and I invite you to read this paper from our Spanish group, where you can see this algorithm to use these new drugs in patients with psoriasis, with HS, with I think we have a space for them, but of course, if your patient asks you which is the best diet for me, we have evidence and we are building more with the Mediterranean diet. And where are we going in the future? We're always thinking about the future, and here I bring Dr. Gelfand again, but because of this editorial in the New England Journal of Medicine, because I agree that we need a next generation of trials in our specialty, in psoriasis. We need larger, to include more patients, like we used to say, like the cardiologist, right? Thousands of patients, 5-year follow-up, pragmatic trials, not only evaluating PASI score, which is good, but also other components of health. And I like the end. Only then will the full promise of this advantage be realized in psoriasis. And this is all. Thank you so much.
Álvaro, that was a really terrific way to start off our session here. This one's working? Yeah. Okay. So this is open for questions. We have a couple of minutes. We have a microphone in the front if anyone wants to come up and ask a question or two. While people are thinking about a question, I want to get a sense from the audience. How many of you here have heard of the GLP-1 agonists? Raise your hand if you've heard of GLP-1 agonists. Okay. How many of you have had a patient with psoriasis go on a GLP-1 agonist? Not as many, but some. Does anyone want to share their experience of what it's been like? Maybe you're closer to the microphone. Do you want to tell us your experience? There's one right behind you. Introduce yourself. Tell us where you're from.
Yeah, thank you, Dr. Gelfand. I am Muralidhar Rajagopalan from India.
Welcome.
I'm also part of the IPC.
Mm-hmm.
I'm very happy with the GLP-1 agonists. I did have a patient with extensive psoriasis. He also had type 2 diabetes. He was latent tuberculosis positive. I started him on a GLP-1 agonist. I actually found a loss of 2 kilos in the first month itself. I put him on 1.8 units.
Mm-hmm.
So I waited for some more time and put him on conventional therapy. I was also happy to see that the MAFLD that he had reversed. I was able to keep him on conventional drugs. I personally am very happy with this particular agonist.
Mm-hmm.
The only one small thing I would like to add is that in addition to drugs, I insist that my patient should exercise.
Yeah.
And it is the only way you can get out of seeing me.
Mm-hmm. That's right. Well, that's thank you for sharing your experience. And it's very different, I think, from the United States, where most dermatologists would not be able to prescribe the drug, although it's a fairly easy thing to prescribe for more economic issues. But I've had several patients in my practice who are overweight, struggling with their psoriasis, cycling through biologics, and I work with their primary care doctors to go on this class of drugs. And it's been remarkable. I mean, they lose so much weight so reliably, and often their disease modulates. Do you want to share your experience? Do you have any patients?
Yeah, I have some patients, some improvement with improvement in the psoriasis, others not. And I think here is where personalized medicine in psoriasis. Now we are treating all patients the same. And maybe here we can identify those patients who are going to benefit the most from these drugs, maybe even first and before using biologics or whatever, but I think they have a space. And yeah, and also all the patients on those treatments, they improve a lot of all the cardiometabolic parameters for sure.
Mm-hmm. And then my next question is, how many of you recommend the Mediterranean diet for your patients? Anyone raise their hand for that? A lot of people, yeah. So this, to me, is a really valuable form of research. I think as clinicians, we want to give people evidence-based data. And one of the frustrating parts is our patients always feel they need to eat less gluten or eat more gluten, or eat the right amount of gluten, whatever it is. And at least we know at Mediterranean diet there's an opportunity to improve their overall health. Whether or not it's going to help psoriasis, I guess we'll figure out from your work.
Sure, and it can be not a boring diet. It can be interesting and with full of products and variety, and yeah, for me it's fantastic. Something coming from nature that can help you improve. It makes sense, and that's why I think it's worth to doing the trials and evaluate. Yeah.
Hervé.
Yeah, congratulations for a very nice talk. In your clinical trial with the GLP-1 agonist, did you plan to integrate some translational, like biomarkers identification for the good responders versus the non-responders? The reason I'm asking is that the immunometabolomics and the metabolomics at large indicates that there are major epigenetic changes, not always reversible, when you switch from a hypercaloric diet to, for instance, a Mediterranean diet. And I suspect that for the, any drug intervention would be the same. So there is already a documentation for the GLP-1 agonists that they are capable to alter these epigenetic changes, which are pro-inflammatory for those ones, but some of those are not reversible. So my question for you is, do you have a sort of translational investigation plan
Yeah, so the trial we are doing is with the Mediterranean diet. We are not doing the GLP-1
Okay.
trial, which could be interesting, and I'm sure it will come. And definitely, it should include these metabolomic parameters and genetic and proteomic.
Yeah, especially because
Yeah.
with the hypercaloric
Sure.
versus Mediterranean diet, you have the same
Yeah.
epigenetic imprints and innate immune cells. So that makes sense to
Sure,
tackle this in the.
sure.
Congratulations.
There's likely to be a lot of GLP-1 trials coming out.
Yeah.
There's so much demand for the drugs that the companies were sort of holding off on IASs for a while, but they are starting to emerge. And I think in the coming years, we're going to be learning a lot about these drugs. All right, Álvaro, thank you so much.
Thank you.